Students, today we are going to discuss an important section of GI tract, anal canal, rectum, colon. So let's start from anal canal. As you know, anal canal is the most distal and terminal part of the GI tract. Okay. It starts from anal verge and goes up to anorectal ring, which is about 4 centimeter from the anal verge to anorectal ring. This is the surgical anal canal, 4 centimeter in length. Whereas the anatomist, they take anal canal from anal verge to the dentate line only, which is about 2 centimeter. Okay, so what about the covering epithelium of anal canal? As you know, the anal verge, the skin around the anal margin, is stratified squamous epithelium, keratinized. It has got all the skin appendages. Whereas as you go inside the anal canal, below the dentate line, the skin changes to stratified squamous epithelium, still keratinized, but hasn't got any of the skin appendages like sweat gland, sebaceous gland. These are all lacking here in the anoderm. But it is sensitive because it is supplied by somatic nerves. Dentate line, as you see, is very important mark. This dentate line is a wavy line. This basically denotes the junction of proctodium with the post-allantoic gut. Proctodium basically is ectodermal, whereas the post-allantoic gut, hind gut, that is endodermal. So below the dentate line, the lining is squamous epithelium. It changes into cuboidal at the level of dentate line, and then above the dentate line, it is columnar epithelium. Okay. So dentate line is a very important line. There is also a longitudinal columns of valve-like structures are there, 10 to 12 in number. These are called anal columns of Morgagni. And in the crypts, the anal gland ducts open. Anal gland ducts are present in the intrasphincteric and submucosal space. They have got duct which open at the bases of these anal columns of Morgagni. Okay. So now arterial supply above the dentate line is supplied by inferior mesenteric arteries, terminal branch, superior rectal artery. Okay. Whereas below the dentate line, it is inferior rectal artery. Venous drainage above the dentate line goes into the inferior mesenteric vein, superior rectal vein, then inferior mesenteric vein, which goes into portal vein by splenic vein and then into portal vein. Okay, so that's a portal system, portal drainage. Whereas venous drainage below the dentate line is into the inferior rectal vein, middle rectal vein, which are tributaries of internal iliac vein, which drains into inferior vena cava ultimately. So there is a portosystemic communication here in the anal canal. It's very important. You see, above the dentate line, it drains into portal circulation, portal venous system, whereas below the dentate line, it drains into systemic veins, inferior vena cava. So this is the point of portosystemic communication. Lymphatic drainage also, above the dentate line, lymphatics follow the superior rectal vessels into the inferior mesenteric nodes. Whereas below the dentate line, lymphatics go into superficial inguinal nodes. Okay, below the dentate line, lymphatics goes into superficial inguinal nodes. Whereas above the dentate line follows the vessels and goes to inferior mesenteric nodes. Above the dentate line, you know, it is ectodermal and is supplied by sympathetic and parasympathetic nerves, L5, S2, 3, 4, and it is insensitive to pain. Whereas the anoderm below the dentate line is supplied by pudendal nerve and it is sensitive to pain. Okay. Now this anal canal it has got a sphincteric complex also. Okay, mucosa is there, submucosa is there. Then after submucosa we have internal sphincter. This internal sphincter is nothing but continuation of the circular muscle coat of the rectum. Okay, and outside the internal sphincter we have got external sphincter. This external sphincter has three components: subcutaneous, superficial and deep part. This external sphincter is under voluntary control. This is supplied by pudendal nerve, S234. Whereas this internal sphincter is constantly contracted and it's supplied by sympathetic and parasympathetic nerve, L5, S234. Okay, so this you have to remember. And anal canal, as you know, is related anteriorly in males to urethra, perineal body and urethra; in females to perineal body, posterior vaginal wall, and posteriorly in both the gender behind the anal canal is coccyx, sacrococcygeal fascia and coccyx, and on each side we have ischiorectal fossa and ischium. Ischiorectal fossa contains some fat, some nerves and vessels cross it. We will discuss about this when we come to perianal abscess and all. So this is a gross anatomy of the anal canal, which is very important to know, because unless you know this, you can't understand the diseases of the anal canal. Now today we are going to discuss an important topic called hemorrhoids, with the general mass called piles, hemorrhoids. What are hemorrhoids basically? You see, as I was discussing in the anal canal anatomy, above the dentate line and in the submucosa, we have got a plexus of vascular plexus consisting of arterioles, venules and sinusoids. And there are some smooth muscle fibers, elastic fibers. Okay, this is more prominent at three positions: 7 and 3, 7, 11 o'clock. And one on the left side, left lateral, and two on the right side, right anterior and right posterior. Okay. This plexus of vein gives rise to internal hemorrhoids. Internal hemorrhoids. So the vascular plexus in the submucosa above the dentate line, this gives rise to internal hemorrhoids. Whereas below the dentate line, the vascular plexus is there and venous plexus is there, and that gives rise to external hemorrhoids. Okay. These anal cushions, as I said, in these three positions, they are present in everybody. Even they are present in an infant which is not born, in utero also. In the mother's womb, the child has got these three anal cushions. These anal cushions have physiological role in continence also. Okay. So what happens because of various problems, sometimes because of with aging, these elastic fibers, they lose their elasticity with constant straining during constipation, with increased intra-abdominal pressure as in pregnancy and other ascites and intra-abdominal tumors. Even with chronic diarrhea and all, these plexus, they can prolapse and come out of the anal bulge. So we grade hemorrhoids accordingly. We say it is grade 1 hemorrhoid when it only bleeds but doesn't prolapse. Grade 2 hemorrhoid when the mucosal plexus, when these when these cushions, they prolapse outside the anal bulge, but they reduce spontaneously. Okay, and we call it grade 3 hemorrhoids when these cushions, they prolapse outside and have to be manually reduced. This is grade 3. Then we have grade 4 hemorrhoid, the hemorrhoids which are permanently prolapsed outside the anal bulge. The moment patient reduces it, it comes back again. This is grade 4 hemorrhoids. So we have got these 4 grades of internal hemorrhoids. Okay. So the causes, as I said, usually associated with old age, with straining, constipation, even with diarrhea, sometimes seen in pregnancy. There is there is a condition in portal hypertension that anorectal varices develop. In portal hypertension, there is not an increased incidence of hemorrhoid. No, the patient bleeds because of the varices and coagulopathy, not because of hemorrhoids. But in pregnancy, yes, the pregnancy causes the increased pressure and they are more prone to hemorrhoids. And as after the delivery, when the pressure releases, these hemorrhoids spontaneously they get better. And so symptoms, what will be the symptoms with hemorrhoid? What will patient complain to you? Usually these patients, they complain that they have got bleeding per rectum. This bleeding is usually painless, profuse bleeding. That's a spurt like bleeding. It is not mixed with the stool. Okay, the stool and the blood are separate. If it is mixed with the stool, it means it is coming from higher up, which we will discuss later. The hemorrhoid bleeding is usually separate from stool. It usually comes after defecation or sometimes before defecation. There will be a spurt of blood, but it's not mixed with stool. And it is usually painless bleeding. Okay. And patient may complain of because of the prolapse, some pus discharge, some pruritus in the perianal region. And if external hemorrhoids are prominent, you will have something outside in the anal warts bulging. When these external hemorrhoid can become thrombosed and lead to very painful condition, thrombosed external hemorrhoid. Okay, so how do you diagnose hemorrhoid? What do you do? What investigation we do? The simplest is we have to examine the patient. And the examination here, we put the patient in left lateral position, Sims position, where hip is flexed, knee is flexed and brought up to the chest, and you do a DRE examination. See the perianal region, put a finger inside and feel for any ulceration or any mass there. Hemorrhoid is one thing which you cannot diagnose by DRE examination. You won't feel a thing. So what we do a proctoscopy. We do put a proctoscope in, draw the obturator with the help of a light, slowly withdraw the scope and you can see the bluish bulge in the lumen of the proctoscope. These bluish bulging are suggestive of hemorrhoids. Usually there are two on the right side, right anterior posterior, and one on the left side. There can be a small secondary hemorrhoids in between as well, but these are the three most prominent things. So this is how you diagnose hemorrhoid. Do you need other tests like flexible sigmoidoscopy and colonoscopy for hemorrhoid patient? Well, yes, in some cases if patient is elderly, above 50-year-old, and his bleeding per rectum is associated with other symptoms, alarm symptoms, like if he has got severe weight loss, loss of appetite, and he has got a change in bowel habit, pain abdomen associated with bleeding rectum, then this is suggestive that he is bleeding from something else, which could be malignancy higher up. And remember, sometimes even with malignancy, hemorrhoids are present as well as a coincidental finding. So if you find hemorrhoid, that doesn't mean he is bleeding only for hemorrhoid. If you have suspicion on his basis of his age, on the basis of his severity of his symptom, on weight loss, anorexia, change in bowel habit, and constipation, diarrhea, altered bowel habit, and so on and so forth, then you should think that he might be having something else, and then colonoscopy is indicated to rule out other pathology. And obviously you do all this CBC, LFT, RFT and all these tests to see for the fitness for the patient for surgery, if at all he will have to be put for surgery. This is how you investigate such patients. Then how do we treat these patients? So how do we treat these patients? You see, treatment depends basically on this grading of hemorrhoids. If it is grade 1 hemorrhoid, the patient is only bleeding, usually you can ask for lifestyle modifications, like if he is constipated, ask him to take plenty of fruit, fiber, vegetable, increase the fluid content, You can prescribe some stool softeners and prescribe bisacodyl or some lactulose, things like that, polyethylene glycol, so that he's relieved, he doesn't have to strain during defecation. And some topical applications can be done of lignocaine or steroids, which can help some patients. Then we usually advise this patient to take warm bath and a tub or so, which is also called SIDS bath. This bath, they sort of give a hot fermentation to the perianal area and reduce the congestion and helps. In most of the patients, they do benefit from this hot fermentation. Then in grade 1 and 2 hemorrhoids, you can also do banding of hemorrhoids with a special Baron's bander, which is done as an office procedure. No anesthesia is needed in this. What we do, this is used for internal hemorrhoids. Above the dentate line, you can put a band, small elastic bands are applied. After sucking out the hemorrhoids in that lumen of the instrument, an elastic band is put. This causes the ischemia and necrosis, and the hemorrhoid sloughs out in 1 and 2 weeks. This is usually good for grade 1 and 2 hemorrhoids. In grade 1 hemorrhoids, sometimes, especially in children, sclerosant can be injected also in internal hemorrhoids in the submucosa with the help of a special needle, a Gabriel syringe and Gabriel needle. We put in the submucosa some phenol in almond oil or polydecanol or sodium tetradecyl sulfate is put, so that this leads to basically fibrosis and obliterates the hemorrhoidal plexus. In grade 3-4 hemorrhoids, internal hemorrhoids, the surgery can be offered to the patient as well. And the surgery there is open surgery. We have got Milligan-Morgan procedure, in which we excise the hemorrhoidal mass, both the external and internal hemorrhoid. Mucosa, submucosa is excised, preserving the internal sphincter. We come up to the dentate line, we tie it with 2,0-vicryl, and then excise the part distal to the ligature. This is called Milligan-Morgan procedure. When we close the mucosa in between the raw area, then it is called closed hemorrhoidectomy. This is called Ferguson's hemorrhoidectomy. Okay. And if it is in grade 4 prolapsing internal hemorrhoids, sometimes a stapler hemorrhoidectomy can be done as well with the help of a stapler gun, which is called MIPH, minimally invasive procedure for hemorrhoidectomy. The staple gun is put in, as a internal purse string suture is taken about 4-5 centimeter above the dentate line, and then with that stapler the anvil is closed and it is fired. What it does, it cuts the mucosa, the internal hemorrhoidal plexus, as well as stitches it. So it's good for prolapsing internal hemorrhoids. It's not good for external hemorrhoids. External hemorrhoids have to be dealt with separately. So this is how you treat hemorrhoids. What are the complications of hemorrhoidectomy? Obviously, in any operation, patient can have excessive bleeding, primary bleeding which occurs at the time of operation, or he can have secondary bleeding and reactionary bleeding. Patient can have infection to the site of the excision. Patient can develop anal stenosis. If you take too much of anoderm and skin, then healing is by fibrosis, and that will lead to anal stenosis. Sometimes fissure can develop. Okay, so I think that much should suffice for today. So, and we have covered anal canal anatomy and hemorrhoid, and in the next lecture we will discuss fissure, fistula and perianal abscess. Thank you.